as we know, our topic is trauma. Okay, so our first question. A 34-year-old man is involved in a motorcycle collision and presents to the emergency department with paramedics. His vital signs are temperature of 98.9, blood pressure 90/65, heart rate of 110, respiratory rate of 30, and oxygen saturation of 91% on room air. An upright chest X-ray is shown. Actually, on the slide, it's not above, it's on the side. Which of the following is the most likely diagnosis? Let's just do raising our hands. So, a diaphragmatic rupture. Okay. Pneumoperitoneum. Pulmonary contusion. Or a tension pneumothorax. Okay, I think that one was pretty clear that the diaphragmatic rupture won out, okay? Okay, so diaphragmatic rupture, a couple of things. They occur in approximately 1 to 6% of severe thoracic trauma. They are most often due to blunt abdominal trauma. They can still happen due to penetrating trauma. They're most often left-sided because on the right side, as we see in the picture, we have the liver kind of protecting the diaphragm. That is also the reason why left-sided herniation is more likely and always needs surgical repair. Because if they do happen on the right side, the liver kind of is big and kind of stops things from going through the diaphragm. So they don't necessarily need surgical repair. The reason it happens mostly with blunt abdominal trauma is because of the trauma, there's change in pressure, and the increase in pressure in the abdominal cavity then literally pushes everything and is too much for the diaphragm to handle. Let's see. In terms, we usually, like we saw in the prompt, chest radiograph is often the initial choice for imaging, but it's not very sensitive. Only about 30% of the time it shows up. You can also get a CT scan, but even a CT scan doesn't always show the diaphragm injury. So the only way to for sure know is laparoscopy. So our next question. A 29-year-old man presents with a gunshot wound to the abdomen. Vital signs are blood pressure of 110/65, heart rate of 90, respiratory rate of 19, temperature of 99.8. The bedside exam is positive. What is the next step in diagnostic management? A, CT. B, laparotomy. Okay. C, MRI. And D, peritoneal lavage. Okay, so for the people on Zoom, there were kind of hands both for A and B. So the answer is CT, given the fact that it's the gold standard for intra-abdominal injuries, and even though there was a positive focus or FAST, the patient's vitals are stable. So because there are so many injuries that can go along with abdominal trauma, having the precise location and the grade of the injuries can be very helpful for surgical intervention. So that's why, since the vitals are stable, the correct answer would be a CT scan. No. No? Okay, Dr. Sinnert does not agree.
No, it's not right. It's not right. Don't you move to the abdomen by the signs, not right? I agree. CT is not sensitive enough to rule out viscous injuries.
Mm-hmm. Well, no, well, it's not saying to not go to the OR.
No, it's laparotomy first, not CAT scan. Okay. No, that's ATLS. Gunshot to the abdomen.
ATLS answer would be to do the CT.
No, it's not.
It's something that they're stable, right? Like, because it's the next step.
Okay, So we have a discussion here, but Dr. G is telling us to move on to the next one for the sake of time. Okay. Okay. So the next question, a patient is involved in a motor vehicle crash. EMS arrives on the scene. There is a local hospital 1 mile from the site and a trauma center 20 miles away. Which of the following findings should prompt transfer to the trauma center? A, the patient has an isolated forearm fracture. The patient is 6 weeks pregnant. C, the patient takes warfarin daily. And D, patient's initial blood pressure is 100/80. Any shout outs? Okay, there are some C's in the crowd, and that is correct. Basically, here are some criteria for transporting patients to trauma centers. Now we're at a trauma center, but in the future, we may not be. So things to keep in mind that the patient, whenever possible, should be stable before being transferred. The receiving hospital needs to have the availability and must be aware that they're going, and they need to records need to be, any records that you do have need to go with the patient. The other thing that was discussed is that if the patient is pregnant and is having contractions, the baby should be delivered first. And then those are the major things. Okay. Our next question, a 33-year-old man fell from a tree while cutting limbs. He sustained significant perennial and genital trauma. Disruption of which of the following structures indicates a testicular rupture? A, the buck fascia. B, tunica albuginea. C, tunica vaginalis. And D, the vas deferens. Okay, some people are saying B, and that is correct. Here is a little review of the anatomy of the testicle. Whenever there's trauma, we need to make sure to examine the external genitalia, the perineum, gluteal folds, to make sure that there aren't any signs of or possible GU trauma. If the rupture has occurred is if the tunica albuginea has been ruptured. And the tunica albuginea is basically a thick fibrous capsule that envelopes each testicle. Urology should be consulted as this needs immediate repair. Okay, so here we have a 25-year-old man presents via EMS with a gunshot wound to the left flank. Initial vital signs are blood pressure of 80/45, heart rate 134. Pulse ox is 93% on room air. He's awake and states that he is in pain. You place the patient on 15 liters oxygen, be a non-rebreather, and place 2 large bore IVs. A fast is performed and shows the image that we see, or a similar image to what we see in the picture. Which of the following is the most appropriate next step in management? A, bring to the operating room for an exploratory laparotomy. B, perform a chest x-ray. C, perform an emergency department thoracotomy. Or D, perform an emergent pericardiocentesis. Okay, that's correct. You want to perform a pericardiocentesis. Basically in the image, we're seeing diastolic collapse of the right ventricle. And this happens because accumulation of fluid in the pericardial space reduces feeling of the ventricles, and thus leading to reduced cardiac output and hemodynamic instability. Basically, the reason that we're more likely to see tamponade in trauma is because the biggest risk factor for tamponade is the speed at which fluid accumulates, and in trauma, it'll accumulate very quickly. And this doesn't mean doing the pericardiocentesis doesn't mean that the patient won't need likely the operating room. You just decompress it to get them there in a more stable fashion. Our next question, a 65-year-old man is an unrestrained rear passenger in a motor vehicle accident. After intubation and central line placement, which of the following is the most likely diagnosis based on the chest x-ray seen above? A, chest wall contusion. B, diaphragmatic rupture. C, pneumomediastinum. Or D, pneumothorax. Okay, pneumothorax, that's correct. So this is an example of the deep sulcus sign on the left. It's another possibility that you see on an x-ray for a pneumothorax. Usually the pleural air in the pleural space goes to the apices, but that's on an upright x-ray. If in the setting of trauma, it might not be possible to have the patient upright, so you do a supine film, and this is more likely what you would see as the air accumulates anteriorly and basally.
Notice too, that patient has sternal wires, so they probably were operated on. So they probably have adhesions holding their lung out to the edge. That's why you're not going to see a good pneumothorax.
Okay. Thank you. So our next question, a 42-year-old man is a restrained driver in a motor vehicle collision. He complains of left flank pain and is hemodynamically stable. Which of the following is an indication for a CT scan of the abdomen and pelvis with IV contrast? A, 100 RBCs on UA, gross hematuria, nausea, scrotal erythema. Okay, so we got some hands for gross hematuria, and that's correct. So blunt trauma accounts for about 90% of renal injuries. Gross hematuria can suggest either an upper or lower urinary tract injury. In cases of clinically significant renal injuries, you will usually see gross hematuria. What I was reading said that microscopic hematuria in adults is not as associated with clinically significant injuries. In pediatrics, it's a different. It can be associated with it. And yeah, so basically, if the patient is hemodynamically stable, then do a CT scan. If you suspect other GU injuries based on your exam, such as a bladder injury, you can do something like a FAST, and you would see fluid in the FAST. Also in urethral injuries, like we talked about in the previous discussion questions, then you can do a retrograde urethrogram. Okay. So our next question, a 35-year-old man presents as a trauma after a T-bone motor vehicle collision to the passenger side. He was a restrained passenger and the airbags deployed. On arrival, he is on a backboard and on a C collar. Vital signs include blood pressure of 88/62, heart rate of 132, respiratory rate of 18, oxygen saturation of 97% on room air, and a GCS of 15. Vascular access is obtained, 2 liters of NS are administered, but his vital signs only improve slightly. His FAST or EFAST is negative. His pelvis shifts during assessment for stability, and X-ray on his pelvis is consistent with lateral compression fractures. Following the initiation of a blood transfusion, which of the following is the next best step? A, angiographic embolization. B, CT of the abdomen and pelvis. C, an exploratory laparotomy. And D, observation. I think most of the hands were for angiographic embolization, and that's the correct answer in this question. Basically, what the discussion for the question talked about was that because the person is hemodynamically stable and didn't have had a negative FAST, so that didn't require a laparotomy, and angiography is a good alternative for controlling bleeding in a patient like this.
No.
Oh, unstable actually.
They are.
Unstable, yes, I misspoke saying stable. Yeah, it's basically because he's unstable, so we need to stop the bleeding, but because the fast was negative, then it recommends an angiography first. Okay. And then the next question, a 23-year-old female presents by ambulance after a motor vehicle crash, complaining of chest pain and shortness of breath. On primary exam, it is unclear if there are bilateral breath sounds, but her airway is intact. Vital signs are a heart rate of 111, blood pressure of 140/84, an O2 of 94% on 2 liters of nasal cannula. On secondary exam, she has a contusion to her left anterior chest. Her supine chest x-ray and the trauma bay is, as we see on the screen. And what is the next step in management? So A, CT chest of the abdomen and pelvis, also a CT of the head and the C-spine. B, large bore tube thoracostomy. C, needle thoracostomy. D, resuscitative thoracotomy. E, small bore tube pigtail. Any hands? Okay. So saw some for a large bore tube thoracostomy, and that's the correct answer. Recently, we've talked a couple of times about the debate between large bore tubes and pigtails, but at least something that for the most part has been a theme is that in the setting of trauma, the recommendation is still mostly for a large bore tube. And at least for the purpose of like test taking, at least on EM Coach, which is where I got this question from, they say that for traumatic pneumothoraces, pneumothoraces, if they're of traumatic etiology, moderate, large in size, symptomatic or attention pneumothorax, if they're bilateral, or if they need mechanical ventilation or non-invasive positive pressure ventilation, or have an associated hemothorax, they say they recommend the large bore tube. And in this case, we have a deep sulcus sign, and we also have likelihood of a hemothorax because of the opacification on the left. So that's why they chose the large bore tube. And our next question, a 32-year-old presents to the emergency department with right knee pain after being involved in a skiing accident just prior to arrival. On physical exam, the patient's right knee shows early bruising, edema of the entire lower extremity, and some superficial abrasions. The lower extremity is tender throughout. Plain films of the knee are obtained, and the radiologist's read indicates a Schatzker type 4 fracture of the tibial plateau. What is the next best step in management? So A, give antibiotics and tetanus vaccination. B, consult orthopedics and tetanus vaccination. C, obtain ABI of both lower extremities. And D, obtain CT scan of the right knee without contrast. E, perform close reduction of the fracture. Okay, so C is the correct answer. So basically here, so Schatzker or tibial plateau injuries have a large likelihood of arterial injury, usually due to concomitant knee dislocations. So that's why the first thing would be to check an ABI, and if it's less than 0.9, then that would be concerning for an injury. Basically, you get the ABI by getting the blood pressure on the arm and then also at the level of the ankle. And then the other thing is that, again, you're still probably going to end up getting ortho on board and even likely a CT scan, but just get the ABI initially as a kind of faster way to start raising or lowering your suspicion for an arterial injury. So I think it's just to compare for the person. Yeah, just to kind of have like a baseline for that person. And then that's it.